Hi, good morning everyone. My name's Chloe and I'm one of the research students here at the EATC. And today I'm just going to be talking a little bit about what my project has been over this last year and what I've been up to. So just to tell you a little bit about me, so I joined the University of Liverpool in 2016 as a medical student, and this was me all the way back in first year when I got my first pair of scrubs. And I really thought that I enjoyed research, and when I moved into second year, I actually started a research project with Dr. Oni at Alderhay, and that was looking at a particular antibiotic called vancomycin and the effect that it has on the kidneys in children. And this project continued into third year, and I managed to present this at a conference when I was in fourth year. And in fourth year, we have the choice to take an extra year out after, just to do an extra year of study. And for me, I wanted to do a bit more research, but other people choose to do medical law or a further study for anatomy. But I really wanted to go back to Alderhay, so I joined the team last September, and this has been me this year doing some work in the labs and working from home as well. And then finally in September, I'll move back into my final year and I'll end up graduating as a doctor. So just to talk a little bit about my project, the overall theme of my project has been looking at ways of measuring how active somebody's HSP disease is. And the ways that we've been doing this are looking at biomarkers in the urine for detecting kidney damage and developing a scoring tool. So just to give a little bit of background about urine biomarkers, obviously Dr. Oni has given us lots of detail on this, but I just wanted to explain this diagram to kind of emphasize the importance of why we've been looking at biomarkers. So if we had 100 children with HSP, we would think that about 50 of them would get better on their own with no medicines needed at all. About 30 patients we think would have some form of kidney problems, but they would also just get better on their own and they wouldn't need any medicines to make them better. About 18 patients we think would get kidney problems, but they would need medicines to make them better. And then about 2 out of the 100 patients would end up developing kidney failure. And these last 3 groups are the groups that we're really most interested in. And we want to be able to develop ways of finding out which patients might get kidney problems, which ones might get the most severe kidney problems, and seeing if we can identify these earlier. So at the moment, as I'm sure most of you will probably be aware, we currently take samples of urine to look for any protein or blood. And if there is protein or blood and it's there for a long time, then it might be that you have some kidney inflammation. However, the best way that we can look at kidney inflammation is with a biopsy, and biopsies carry risks of things going wrong, and it's quite a big procedure, so it's not really something that we could offer to every child that has blood or protein in their urine. So what we want is another way that's a bit less invasive of looking, that's an earlier sign of kidney damage. And the best way that we thought to do this was by looking at biomarkers. So a biomarker could be any protein or molecule that's found in either the blood or the urine, which may tell us that something is going wrong. Excuse me, sorry. And most biomarkers that we look at the moment aren't normally available in a routine lab, and they're sort of different proteins to the ones that we normally look at. And we thought that this was the best way to go forward. So the aim of this part of my project was to have a look at the data that's already been published to find out which biomarkers have already been identified that might be able to detect kidney problems in IgA vasculitis. So when we searched for all of the papers, we used 4 different search engines and we found 121 records. And of these, there were a few that there were more than one of the same paper, and some of them just weren't really relevant to what we were looking for. And we found that there were 13 studies that were relevant to what we wanted. And over these 13 studies, we found there were 2,446 children, and 51% of those were male, and the average age of them was 7.9 years. And across these papers, we found there were 23 different biomarkers that they mentioned, and 3 were traditional, which pretty much means that we already are able to look for them in the lab, and 20 were novel biomarkers, which means that they're not routinely available. And of these 20 novel biomarkers, we found that 5 were reported more than once, and 4 biomarkers were found to be significantly associated with either predicting kidney involvement or assessing how severe someone's kidney involvement was. And these are the 4 biomarkers that we found. So we have KIM1, MCP1, NAG, and AGT. And these are all just different proteins that are produced from different parts of the kidney. So in conclusion, for the first part of my project, we just found that there are some promising biomarkers in the urine, and they may be able to help us detect kidney damage earlier than normal protein or blood, and may help us to tell which patients might get kidney failure versus those who won't. One of the biggest things we found is that we really need more research into these biomarkers, and there's lots going on, and hopefully I'll be able to get into the lab and we'll be able to test some of the patients that have come to Alder Hey and have kindly given us some urine samples, and we might be able to see if we can find these biomarkers in their urine. If anyone is interested, we've recently published a systematic review on this, and if you want to have a look in any more detail, then it's free to access. Moving on then to the second part of my project this year, we wanted to create a scoring tool and create, develop and test this for patients with HSP. So as I mentioned earlier, we have around 2 out of 100 children with HSP that will develop kidney failure, and that number's not really changed for a number of years now. And as we've already said, we really need more research looking into different medicines that may help these patients. But there's not really one way that we describe patients and the symptoms that they have, and this makes doing research really quite difficult. And a scoring tool would help us and other doctors, anywhere we are in the world, describe patients in a similar way. And it might also help find out which patients are the most poorly and which may need more medicine than others. So at the moment, there is a scoring tool called the PVAS, and this scoring tool is used for all children that have any kind of vasculitis. And because of this, there's quite a few symptoms on there that patients with IgA vasculitis just don't really get. So we don't think that it's a very good representation of the symptoms. So instead, we've created a scoring tool called the IgA Vas, which is more specific to patients and includes a big variety of the symptoms that they might get. Just to break it down a little bit more, so the IgA Vas is a scoring tool that has 40 different symptoms on it, and these different symptoms are categorized into 5 different domains, and overall it gives a total score out of 125. So the 5 categories are, we can see on the right, so we can have skin symptoms, which basically just describes the type of rash and where the rash is. We have tummy and gut symptoms, which includes when you get tummy pain and how bad that is, and then other things like diarrhea and vomiting. It also includes joint symptoms, which might be pain or inflammation, swelling and muscle aches, kidney symptoms, which can help us identify blood or protein in the urine, and other markers of poor kidney function. And then finally, we just have an other category, which includes things like having a fever and weight loss. For the methods of this part of my study, what we wanted to do was take a group of children that had come to Alder Hey in between 2015 and 2019, and we wanted to use our medical notes to score them using both the old scoring tool, the PVAS, and the new scoring tool, the IgA Vas. So it was myself and Dr. Oni who scored these patients, and then there was another doctor who also scored them using a 0 to 10 visual analog scale, where 0 is happy and healthy and no problems, really completely well, and 10 is the most poorly that they could be. And we then took this data and analysed it and put it into some graphs. The main aims of this project, we wanted to look at, well, does the IgA Vas do what it is supposed to do? Does it identify patients who are poorly? And does it describe them better than the PVAS? The second thing we wanted to look at was, does it correlate with the 0 to 10 scale? And the 0 to 10 scale is just sort of an overall marker of how well the patient is. The third thing that we wanted to look at was whether the PVAS correlated with the IgA Vas, and the PVAS is sort of what we would call the gold standard, so it's the best thing out there at the moment for describing patients with IgA vasculitis. So we wanted it to correlate with that. And then finally, we wanted to look at how similar mine and Dr. Oni's scores were. So I'm just going to talk you through a couple of graphs that we made. So this first graph is looking at, so along the bottom we have the score given for the IgA Vas, and then the total score for the PVAS on the left-hand side. And what we can see is that there is sort of a trend of the, the higher the score for the IgA Vas, the higher the score was for the PVAS. And it's a little bit messy, but you can kind of see that there is a bit of a correlation. And then the second diagram is looking at mine versus Dr. Oni's scores. So along the bottom, we have my scores for the IgA Vas, and along the left-hand side, we have Dr. Oni's scores for the IgA Vas. And what we would have really liked to see, if this was a perfect graph and me and Dr. Oni had scored every single patient exactly the same, this would have been a perfectly straight line. But as you can see, it's not really like that. It's a little bit messy and a little bit cluttered, but there is still a pattern there. It's just not as perfect as we'd like it to be. So in conclusion, when we think back to our aims about this part of the project, we wanted to know whether the IgA Vas does what it's supposed to do, and we kind of did feel that yes, it did. It did seem to summarise patients and the symptoms that they have quite well. We also found that the IgA Vas did correlate with the 0 to 10 scale, which was really positive. And as well, it correlated with the PVAS, which is really great, and that's what we wanted to find. However, what we did also find was that mine and Dr. Oni's scores weren't very similar, and this is the main area that we would need to improve on for the future when we think about developing the scoring tool a bit further. So thank you very much. If anyone has any questions, I'd be happy to take them.
Thank you, Chloe. I just wanted to ask a little bit about how understanding the science and stuff is going to help you as a doctor going forward.
Yes, it's a good question. I think it's really helped me to understand on a different level this condition, and particularly how it affects patients and the things that are important to them. I think when we think about research, it always has to come back to the patient and what what this is actually going to do for them and how this is going to make their life better. And I think going forward, that's probably the main thing that I will always remember when thinking back to the science that I've done.
Excellent. Well done. Great job. Any other questions?
Chloe, that was a really nice presentation. Thanks very much. I just had a question about your biomarker work. So you say you're going to find all of these biomarkers and hopefully that they will tell you which patient is at risk of developing kidney problems. But how would that actually be tested in a clinical setting when you get to the hospital? What would be the plan?
Yeah, so it's a good question, and it can be a bit complicated because we still don't have a lot of evidence pointing towards one particular biomarker yet. So we would still need a lot more before it was actually used in a hospital setting. The way that we would kind of go forward with it is that once it's been tested in much bigger cohorts, we would then be able to take a urine sample like children with IgA vasculitis would normally have now, send it off to the lab, and they'd be able to test this biomarker in the lab and see whether it was present or not. But as I said, we're still quite a long way off from that, but in the future, that's how it would go about being developed.